Thank you for attending on a wet and rainy evening. Just the one item this evening to get through. If we go straight into the agenda, apologies for absence.
Apologies from Councillor Moore, who's being substituted by Councillor Fry.
Thank you. Okay, the minutes of the last meeting from 18th of November last year. Everyone who was here, are those a fair and accurate reflection of the proceedings of that meeting? Okay, I'll take that as a yes. Any disclosures of interest?
None, Chair.
Any urgent business?
None, Chair.
References from committees or other bodies?
Again, none, Chair.
Okay, I have nothing to update the committee on that's happened since the last meeting. Okay, so if we go straight into this evening's report, item 7, improving resident experience of access to primary care in Luton. If we can fix that. Okay, so apparently Amanda Flower from the ICB is not with us yet, so if we can just we'll just pause for a few minutes, wait for her to join us. Good evening, Amanda.
Hello there, good evening.
Hello. Yes, if you would, if you'd like to carry on and deliver your report.
Will do, thank you. Good evening, everybody. I'm Amanda Flower. I'm Director of Primary Care with BL&K ICB. So I'll take you through the headlines from the report that we provided with you for you this evening, and then very happy, obviously, to take any questions. So this report follows previous reports that we provided to the committee and provides you with an update on the work that we're doing with our general practice teams and community pharmacy teams in Luton to support resident access to primary care. So the paper starts by explaining primary care is the range of first point of contact services that residents have with healthcare. And when we talk about primary care, we talk about general practice, community pharmacy, dental, optometry, and the 111 telephone service that many people will be familiar with. This report specifically focuses on general practice and community pharmacy. So since the 1st of October, it's been a requirement for all general practice to ensure that their registered population know on the day they contact their practice, either by telephone or walking into the practice or via the online consultation system, that they know on the day they contact their practice how their query will or their need will be responded to. That's not to say that they will be given an appointment on that day, but they will know what the outcome of that request is. The core hours of general practice are 8 a.m. till 6:30 p.m. and in an effort to reduce the burden and often the frustration of people trying to ring, online consultation systems have been introduced. Hopefully the online consultation system is available to some of our residents, and that way freeing up the telephone lines for those who can only access their surgery in that way. NHS England have produced guidance that's available on every practice website, so should be accessible to residents, and that describes what the population can expect from general practice, and it summarises some of the things that I've just mentioned. Residents will be aware that when they contact their practices gather a range of information. Now, whether a resident contacts practice by telephone or attends the surgery or uses the online consultation system, they will be asked for consistent information. And that allows the clinical team at the practice to understand the resident's need or request so they can provide the right response. And that response may be an appointment on the same day or a subsequent day as indicated by the presenting need, a phone call from the member of the practice team, a text message that may, if it's an administrative type query, or advice to go to another service such as community pharmacy. Residents will not always be seen by a GP. The clinical team in general practice is changing and diversifying, and to improve access to residents, we've appointed more members of the clinical team. So going on through the report provides to the committee an indication of the level of appointments that are being offered by practice teams in Luton to residents. There continues to be increased demand and an increased number of appointments offered by our Luton practices. We, on average, see an increase year on year of 10% in the number of appointments that our practice teams are offering. And the numbers that I've quoted in the paper give you a specific period of October. And when comparing October 2025 to October the previous year, there were 15% more appointments offered in that period. What we're seeing with the changes, the contract changes that I've outlined from the 1st of October, we're seeing a difference in the take-up and the utilisation of appointments. Currently, 53% of total appointments are on the same day or the day after being booked. So quite a quick turnaround in terms of appointments for a number of residents. As I've already mentioned, a significant number, and more than 50% in October, more than 50% were with a healthcare professional other than a GP. As many of you will recall from previous reports, we now have the advantage of advanced telephony systems in general practice. And these systems are really important because they allow us to understand the real demand. They allow us to understand the number of calls that flow into practices, the calls that were answered, the calls that were not answered, and they allow us to understand peak time for calls. So whilst we've had the benefit of online consultation systems for some time, and that's been a requirement of the contract since the 1st of October, the peak time for calls does remain at 8 a.m. in the morning when the services start. And we know that some practices are unable still to answer all of those calls, and we're working with our practice teams to improve that. We are seeing a significant increase in the utilisation of the online consultation system, which is what we expected to encounter. So over time, we expect that to continue to grow and hopefully to see some of that telephone call demand reduce. And as I've already said, allow people who can only access their practice via the telephone, allow that route for those residents. And that should hopefully lead us to an improved call response. All of this is caveated with the demand for general practice. It remains incredibly high, and practice teams work really hard to meet that incoming demand with the finite resources that they have available. So what I've included in the report for you is to show that how community pharmacy are increasing their offer to residents. And in Luton, we've seen significant success in utilising the offer made by community pharmacy, the Pharmacy First offer. So we're seeing an increase quite steadily in the utilisation of Pharmacy First. And using the pharmacy first offer in that way means that residents who need the support of their practice team have a better opportunity to access them with lower complexity, residents with lower complexity needs being able to access their community pharmacy. So we recognise that there are still some examples where residents are not able to either contact their practice via the telephone, and there are still some challenges for some residents in using that online consultation system. We are working closely with our practices to ensure that they use all of the data available to them, that they really understand that incoming demand and they can flex and use their capacity accordingly, and that they can really target support to residents so that they understand the access routes into their team and that they understand how primary care is changing and how to use online consultation if they're able to do so. And the ICB supports this work through a series of regular practice visits where we discuss with the practice their progress in supporting and improving resident access. I'll stop there, Chair. I'm very happy to take any questions.
Thank you. Okay, yes, does anyone have any questions? Councillor Ahmed, then Councillor Hussain.
Thank you, Chair. With many residents reporting difficulty getting in touch, getting through to practice at 8 a.m. or on Mondays, what support is being given to help practices manage peak call demand, for example, through staggered staffing or alternative call handling arrangements?
Thank you for the question. So as I explained, we've got the benefit now of cloud-based telephony service, those advanced telephony systems, still quite new to practices, but that really shows us the peaks in demand and when that demand is coming in. There's been significant investment into general practice through additional roles, and as I've explained, most practices have the benefit of a range of professionals available to them now. The demand is still significantly higher than is often able to be dealt with by practices, which is why we're trying to facilitate and support utilisation of other services such as community pharmacy. We do appreciate that there are still some frustrations and still some access challenges for residents. The work that we're trying to do to understand that demand, to understand how practice teams can respond to that, but to look at the alternative options for residents to use to ensure that general practice is preserved for those who need it the most.
Councillor Hussain?
Taking on to what the colleague has said, one of the things that I've recently had the, a number of residents have complained about is that by the time it comes 8 o'clock, they've tried it online, and when it comes to 8 o'clock, all the appointments are gone. That's for a starting one. Then they go into the pharmacy, and this is, the Leevale, I'm talking about Market Square, to the pharmacist. And the pharmacist looks on the individual that they have got a very serious thing on their eye, and they're about, literally can't see from that eye at all. So they advise them to call 111. It takes them about a couple of hours, and they do get an emergency appointment. Now, this is the norm. Does anybody monitor these things that where the number of, and I can name those few of those, one that I get a lot of complaint about is Medici is one of them. 8 o'clock in the morning, Medici's appointment is gone. So what is the point of making telephone available when there is no chance of an individual resident getting an appointment?
Yeah, and this. Thank you for the question, and I'll attempt to answer that. As I've said, demand remains considerably higher than general practice is well resourced to deliver to, and we're trying to improve the offer and think about alternatives such as community pharmacy I've mentioned. And the intention behind that is to ensure that we preserve general practice for those that need it most. Now, what should be happening, and I appreciate that this is it's a time of change and a time of transition. What should happen is that previously, with old systems, people referred to the 8 a.m. scramble. So those that got through first got the appointments. And that was what happened historically. And I appreciate still happens now to some extent. And the description you've provided is a familiar one. The new system that we're working with practices to introduce attempts to take away that first come, first served basis. So it should be that patients who need to be seen either on that day or in a certain timescale do have access to an appropriate appointment. However, there are times when demand continues to outstrip supply and practices become very challenged. I've noted down the example that you provided and the practice name that you've provided, and I will look offline if there is anything unique about that practice's demand and capacity to see if I can understand if that practice has a specific problem. I'm always very happy, as are my team, to be contacted about very specific things to see if we can support residents and also support practices who, as I'm sure you all agree, are working incredibly hard to support their registered population. So thank you for that comment and thank you for that feedback.
Chair, can I? Yeah. What I'm saying to you is that, I can probably contact you. I'm talking about general public have no way of able to get through to anybody else whom they can make a complaint or to get, they finish up. And I'm giving you not just one example, many examples in the recent months where they call 111, done it 20 minutes or so, the call that takes and goes on and on. They've managed to get then appointment. If they can do that by dialing 111, why is it they can't do that with their own GP practice where they can leave a message, somebody can get back, and then if it's taken into account, if their need is serious enough to give them a GP appointment. That's what I'm saying is, it's fine for us really, or for me to do you an email. But what about the general public?
And if I may come back then, so all practices should make clear to residents that if residents want to raise a concern, they should make clear the routes to do that. And residents can also complain or raise comments through to the ICB. And I can see my Health Watch colleague on the call as well. So there are a number of routes where residents can raise comments or concerns or challenges if there are continual access problems. And the scenario that you've described is a difficult scenario. Patients can often find themselves sort of going around in what feels like a loop, trying to get access, and that takes time and that is frustrating. And we are working with our teams trying to resolve that. Unfortunately, it takes time, demand is high. And as I've said, I'm happy to be contacted, but there are complaint routes that are visible to residents, or they should be visible. And if that isn't the case, I will work with those practices and with my team to have a look at that.
Thank you. Okay, Councillor Begum, then Councillor Steer, then Pat on Teams, then Councillor Fry.
Thank you, Chair. Thank you for the report and for the data. My question is actually partly covered by Councillor Hussain, But I want to share something recently while I was off sick faced, not myself. The cases came to me, 3 cases. In your report, you said they can walk in, they can call, they can do online consultation. But if residents, and I have 3 cases of this, have not been able to get an appointment regardless of doing all 3, they have been consistently been turned away by surgeries. 2 of those residents had been admitted to hospital 3 weeks after for 3 weeks for trying to get an appointment. So I completely agree with Councillor Hussain what he said with the residents facing those. And if you look at these cases, they were serious. Who decides what is serious and what happens to those surgeries who are not giving appointments to these residents? So that would be my question to you.
Thank you. So it's very difficult for me to comment on individual cases, but very happy to support those outside of the meeting. We, as I explained towards the end of my report, from an ICB perspective, we have a regular review process with practices. We review a range of data and information with practices. We have a range of indicators that we look at with them. And to understand where their challenges are, and where they are progressing, but where there are constraints or where there are challenges. So the ICB does that contract monitoring and contract support with all of the general practice teams in Luton and across BLMK. We also bring into those discussions known issues and complaints, which is why it is important, if there are persistent issues with practices, that we are made aware of those and we can work with those teams to try and support and bring a resolution.
Thank you. I think, no, it was an individual case. I would say, I think what from Councillor Hussain has said is across Luton. Many of our colleagues facing it, when you have our surgeries, when you speak to residents on the door, the main issue is not being able to get an appointment. My question was, obviously these were serious cases that came to my attention, which I was going to send an email to chair. But many residents are facing this. What are we doing to make sure the surgeries are not turning away residents just by saying, oh, we don't have any appointments? And also to follow up from Councillor Hussain, how can all surgeries be gone with appointments by 8 a.m. if the line is open at 8 a.m.? So if I were to call tomorrow at 8 a.m., 1 minute past 8, I would be told, oh, there's no more appointments. If I were to go to surgery, they would say, oh, we can't see you. And again, if you were to go undercover without our badges, I would be able to bring you surgeries in cases of receptionists telling us, no, you can't book, come here, you have to go online, or you call tomorrow at 8 p.m. They are doing that to residents. How are we making sure that, obviously, as Councillor Hussain said, we can come to you? How are we making sure residents are happy with the service? And they don't want to complain. I'm sorry, but many residents don't feel confident to complain because it doesn't do anything to them.
So, as I've explained, the ICB holds contracts with each of these practices. We do regular review visits to each of the practices. We have a range of information and data, some of which I've presented into the report to you today. There are a number of appointments, and that number of appointments continues to rise. We have a good indication of where practices are delivering a good number of appointments, or where they are not delivering the number of appointments that you may expect to be delivered to that population. And that forms part of those contract review visits that we undertake with practices.
Thank you. I'm sorry, but that's not the answer I was looking for. I mean, yes, you have a contract, but what I was looking for is, is there a penalty? What is the consequences of them turning away severely unwell residents who then end up in hospital? That's what I'm trying to find out. Yes, the report is good. Thank you. There are data. Thank you. But what I'm trying to say is, what about those people that have been neglected? What is the consequences on those surgeries for neglecting those patients they are supposed to care for? Thank you.
So Of course, there are processes and systems where patients or residents have been harmed or where there are clinical risk and issues. Those are reviewed and those are responded to appropriately. It's quite difficult for me to comment about individual things. We take assurance of practices and the clinical services they offer. That's the role of the ICB, and we do that. There are complaints processes, and those complaints are responded to. If we are aware of incidents of harm or safety to residents, they are investigated fully with the clinical team. I think you asked me whose decision it is, who is seen and not seen. It is the clinical team in a practice who undertake the triage or review of patients' needs and allocate appointments accordingly.
Okay, thank you. Can I just follow up on that point that Councillor Bacon has made, that about providing a service? Obviously, the practices, PCNs are contractually obliged to provide a particular service. Is there any contractual obligation to provide a particular level of service? Do you have, does the ICB have a service level agreement, for example, with the practices?
So the general practice contract is a national contract, and it states some of the things that I've included in my paper to you. It states that the practice has to be open from 8 a.m. till 6:30 p.m. It states that patients should be able to access an appointment relevant to their presenting need, either via the telephone, online consultation, or by attending the practice. It states a number of things, and those are the things that we cover when we undertake a practice visit. So we look at the level of activity, the staffing, complaints, incidents. We look at all of the data available to us when we undertake a practice visit. If a practice isn't performing as we would expect them to perform, there are processes in the contract, remedial action plans and breach notices that we can use if we think that they will bring improvement and bring benefit for the practice and for the registered population. And that is the ICB's role.
Okay, thank you. Councillor Steer?
Yeah, thank you. I've got a separate question, but if you can indulge me, just want to follow on this conversation, because I think what we're getting at is the triaging of patients. Is that good enough? If you take Councillor Hussein's example, where somebody has phoned a GP practice because they can't see out of one eye and they are sent to a pharmacy, is there any monitoring of the triaging and how good that is?
So there is, I suppose, if you think about the what you're describing and the monitoring of triaging, so there is a range of things that we do. So we oversight the contract, as I've described, as an ICB, but we also have oversight of the quality. And if there are quality concerns, obviously all practices are also regulated by the Care Quality Commission as well. So there are a number of opportunities to review the quality of patient care and patient triage as a part of that. And I think, that the sort of incident reporting that I've described and complaints are all a factor in understanding how a practice is delivering clinical care to its residents.
I don't think that's quite what we're trying to get at. And the point the chair made, if somebody phones a GP practice at 8 o'clock in the morning and they've got something pretty serious, is there any monitoring that they have not been given an appointment, or that, for example, somebody has phoned and you would think it was a less serious case and they have been given an appointment? Is there any monitoring of that?
So it's very difficult for me to comment on individual clinical.
Sorry, this is not an individual case. I'm making the point from the triaging. Is there any monitoring of who does and doesn't get a GP appointment and what they've found with their ailment is?
So there's a couple of things that can happen. So clinicians in the practice will have oversight for each other's work. So essentially, there's something about working as a clinical team. The decision making is checked by peers and reviewed in that way. I think the other thing that happens is if the 111 service, which is an example that you've described to me, received a call from a patient that had or had not been seen in the practice and was concerned about the care that resident had received or not received from its practice, they would raise that. We also get a number of examples where our colleagues in secondary care will raise concerns or raise examples where patients have attended A&E and they maybe should have been seen in their practice. So we do have the opportunity to understand the flow of residents through the system and understand where there is a particular potential issue of residents not getting access to an appointment, which may indicate that the triage process is not correct at a practice. But I suppose if you're asking me, do the ICB have the opportunity to review every triage intervention that a practice makes? No, we don't. We cannot review in that level of detail.
Yeah, I get that. Chair, I wonder if we could pursue this perhaps with another report on the triaging, because it seems to me fundamentally important, if you agree.
Yeah, so this is something that was that concerns me as well. Is there seems to be the telephony systems seem to be working, seem to be doing that part of the job. Part of the system seems to be working well, but it does seem to be, once you get to the triage system and the booking system, there seems to be some kind of disconnect there, and that's it's hard. It's obviously hard for us to judge, and perhaps hard for yourselves to judge whether this all the information that we've given you this evening, whether that is typical or it is isolated or whether it's somewhere in between. So it's obviously very hard to get a picture of what is happening, but I'm getting a picture where there seems to be issues, however widespread, with triaging, and then also with the booking system where someone can ring up at 8 o'clock and find that there are no appointments available. So I'm not just for our next primary care access, perhaps we could have some more information on the triaging and the booking systems that the practices are implementing, and how we're trying to tackle the issues that have been raised this evening. If that sounds reasonable. Does that sound reasonable, Amanda?
I think it might I think we can probably bring back more detail about the triage process and how clinical teams undertake triage, and perhaps we can bring back a bit more detail about how clinical teams peer review and ensure patient safety and patient safety processes. So I can have a think about that. I may benefit from a further discussion outside of this committee about that. So we really pitch that report correctly to answer some of the questions and concerns that the committee has.
Okay, thank you. Yeah, the general structure of these reports that we get at each meeting don't seem to vary that much. We have a bunch of high level statistics, town-wide statistics. So I think it would be useful to have a bit of a deeper dive into that particular aspect that seems to be causing some issues for our residents. So yeah, thank you. Who's next?
Sorry, can I go to my
yeah.
question?
Yeah, sure.
Which was something completely different. So under paragraph 6, it talks about a 15% increase in appointments, which relates to approximately 20,000 extra appointments. What were people doing previously when they presumably couldn't get appointments? What?
To be honest, I can't answer that. All I can talk to you about is the teams that I have responsibility for. We're seeing a growing, I've said we've seen increase in we see a continual increase in demand that equates to approximately 10% year on year. So some of that will be that sort of linked to changes in population growth. I can't answer where those residents were seeking support previously. I don't have information to that effect.
So you're saying there's a 10% increase in demand year on year?
10% increase in appointments offered by general practice teams.
No, you said demand. You said demand.
I said there is an increase in demand, and in response to that, practice teams are offering an increased number of appointments.
Right. Do you know why the demand is going up so much?
Population growth, levels of need in the population.
It's quite a number, isn't it, in a year? Is demand not generated because appointments are more readily available, or is it the health of the population as well as the expansion?
I think it's multifactorial. I think growth in the population. I think the presence of long-term conditions and people managing more long-term conditions at home and in the community, and their first point of call is their general practice team. I think there's a range of factors that contribute to that increased demand and that percentage increase that general practice is delivering in appointments. But it is a significant increase in appointments year on year that we see.
Okay, thank you. Thank you, Chair.
Thank you. Pat, would you like to?
Yeah. I'll share some information that we have before I give you my question. As in, we take feedback from the population of Luton on their experiences, either through many of our social media, website or telephone. And since October, the triage system has been working better. Where that 8 o'clock in the morning doesn't seem to be a problem anymore. And many GPs' practices, their triage system are open till lunchtime or throughout the day. Many GP practices offer, if you can't get an appointment at that GP, you could get an appointment at a GP within their PCN. So, many of the GPs offer that. We did have some complaints from some GPs. I'm not going to name them. But we worked with the PCN of them GPs and we did some secret shoppers at GP practices after we'd worked with them, and the 2 GP practices that we did the secret shopper on came out very well. There wasn't a problem. We contacted them in the morning. So I think services are getting better, and that was good. If anybody does put a comment on our website or phones us up, we do refer them on to the ICB. And in most cases, we get people to do it themselves, but there are times that we, support people to do that if we feel they need it. I will say the triage system, we did a survey, we did 100 postcards, events across Luton, so across all of Luton, where we didn't ask them what GP they were at. We missed that question out. We should have done. The feedback from our survey was that some people had no problem getting a GP appointment. The system really, really worked for them, but some people, there was a problem. And some of the areas that we have identified with the triage system is vulnerable adults, people that can't if people can use the triage system online, they're laughing, they can get through and they don't have a problem. But those vulnerable groups or people who can't write English, there is a real problem. So a person that doesn't have access to the internet, they might have difficulty phoning the GP. Some GPs will say you have to go online when they should be offering that service over the phone. And some GPs, it's really difficult to get that service over the phone for them that might be elderly people and quite vulnerable. And also English as a second language. You have a triage system that is in English, and if you can't write in English, you obviously can't access that service. And again, there might be GP practices in the area that have a high population of people that can't write English, and then there is a difficulty in that practice. Yeah. But I will say overall, since October, the system has really improved. And I will quickly say our feedback from pharmacy is excellent, and our feedback from 111 is excellent. And 111 can offer GP appointments as well, can't they? Yeah.
Yeah, the 111 service, well, out of hours, they will book into the GP out of hours service, but also what is available is that if a resident rings 111 and they can be seen by general practice, 111 can book them into a general practice appointment with their usual registered practice. So yeah, that does happen. But thank you, Pat, that's good feedback and good to hear that there is some improvements for some residents. The online consultation services are still quite new, and I think you've picked up some really important points there about how practices support residents who don't, who can't use an online form and who perhaps are not comfortable using digital systems, because it's really important that practices guide those residents through the processes and support them. That the contract changes on the 1st of October were really designed to bring about equity of access, and it's really important that practices provide that support to residents. So important points that you've raised there about how the triage system and the collection of information at the point of triage works for all of the registered population. So thank you for sharing that information.
Councillor Fry?
Just following up from that information we've just been given, going forward with you said there's been an increased use of the online. Has that had any effect on the telephony utilisation?
So at the moment, unfortunately, we are still seeing the heaviest demand at 8 a.m. for the telephone. So So there's still high demand at 8 a.m. of people ringing their practice. And then there is this high demand through the online consultation. But it's pretty early days. It's January, online consultation. Whilst a number of practices were doing it pre-October, it was formalised through the national contract from the 1st of October. And I think what Pat's described and what others have described is how we work with practices and with residents to understand each of these different routes that they can get help through, and perhaps over time we'll see a more balanced use of each of those access routes, and hopefully take away that frustrating time at 8 a.m. when the phones are very, very busy. But at the moment, it isn't showing through in the data in that way.
Just as a follow-on to that, do we know whether people are giving up on the phone and then going on to the online?
So there is in the online, in the telephone data that we've got, we can see where people discontinue their call, and we do have that information. Now, the telephone data doesn't obviously identify who, so it would be very difficult then for them to establish if they'd gone through the online consultation. But we certainly know there are a number of residents who abandon their call, maybe because they've waited too long, or but maybe because they're busy and they've got to go and do something else. So one of the things that we want to do with our practices is to increase the number of telephone calls that they answer and complete, and reduce the abandoned telephone call number and the drop call number, because that helps residents to make sure they're getting the response that they need. And all of that telephone data that I've referenced is again what we talk to practice about in those practice review visits.
Thank you.
Councillor Arles, you had a question?
Thank you. It was just to go back to what my colleagues have referred to about the triage. If you could include in the report an assessment of how, when people go into the surgeries, how they are assessed and who assesses them. Because obviously I think that's what the issue is sometimes. Because sometimes the calls are that it's the person on the other end of the phone that does the assessment, which is not necessarily a clinician. And also then people can't go into the surgeries because they're told not to come into the surgeries. So if that could be included on how the initial assessment is carried out to decipher who gets seen or who doesn't get seen, please, if that could be included as well. Thank you.
Okay, thank you.
That's helpful. That helps me to think about the future report and how to pitch that information. Thank you.
Okay, any more questions? Councillor Ahmed, then Councillor Ambia. Then I think we'll wrap it up.
Thank you, Chair. Would it be possible for this committee to receive an update report in 6 months' time on progress against the action outlined in this report?
Councillor Ahmed, we have this is a regular standing item, so we will be having that sort of information, and we're going to have discussions about the particular issues around triaging. So, okay, I think that should answer your question. Councillor Ambia.
Thank you, Chair. On the as per the report, section 6, he have mentioned there's a significant appointment number has increased, and I think this in connection with the population growth. So my question is, are you going to working with GP practice to maximize or to expand their resources or recruit a new GP, or do you have any discussion with all the GP partner is there any resource or facilities ICB can accommodate to meet the increasing demand? And also my second question is, this modern practice access, it is benefited for particular group people, those who are like IT literate. They can log in online and they can book, and slot is taken. That's why my colleague raised a concern. Elderly people, when they call at 8 o'clock, by the time it's been everything taken through the online appointment. So is there anything ICB can make any for allocating a quota system, people who can, for like non people who are unable to book online, say telephone or walk-in patient? I understand like GP wanted to fill their space as soon as possible for there to meet, this is for the business interest, but if their ICB can set a role to have some sort of certain number that will be for allocated for walk-in or telephone call. Thank you.
Thank you. So I think the first part of your question was about our practice resources increasing to meet demand and to continue offering more appointments. So each practice has an income, a contract value, which they use to provide staffing and to provide resources to cater for their residents' needs. As I've tried to explain in the report, there has been investment in workforce to recruit new roles into general practice, and the practice teams and primary care network teams have grown. So there is investment being made. I think the next part of your question related again to the triage and how if residents can't use the online consultation form, how do they get access, and is access still available through phone and attendance? And it should be. So the national contract for general practice states that irrespective of how a resident contacts their practice, either online or attending the practice or telephoning, the practice team will need to collect the same information so they can understand the patient's need, but patients should have the same access to appointments in the same timescale. So it shouldn't be that the person who gets through on the telephone at 8:01 gets the appointment. It should be the person who has the need, and that is what triage is designed to do. Triage is designed to understand need and the right response to address that need. And from the feedback from the committee tonight, I think there is still some examples of where the perception is that still isn't happening as effectively as it could do, and we'll attempt to analyse that and bring that into a future report to answer some of the committee's questions.
Okay, thank you. I'd like to, okay, Councillor Fry. Yeah.
Sorry, just one last question relating to points 7 and 8. The figures there, how do they compare nationally?
So in terms of benchmarking, we as BLMK, our appointment figures are benchmark fine nationally. One of the roles that we undertake as a ICB is to understand where there's variation, and those practice visits that I've talked about that bring together ranges of data obviously do that on a practice level. So if a practice has data that is outside of what we would expect for their registered population, that's what we review through those contract meetings. So obviously I've not provided the data at a practice level for the purpose of this report, but the ICB does regularly look at data at each of our practices and look at that from a BLMK, a regional and national perspective in terms of focusing those conversations with practices.
Okay, thank you. Thank you very much, Amanda, for the report. I think if we can arrange a time for a meeting to talk about the content of that future report around triaging and the booking systems, that would be great. Okay, thank you very much.
Thank you.
Okay, if we go on to the last item, the draft work program. I think we thought there was an issue, but I think we've sorted that one out about the mental health strategy report. And I don't think there's anything else that we need to talk about at the moment, but I think it would be a good idea at some point in the near future to have a meeting between myself and the appropriate people about the future work plan. So, for example, we don't end up as tonight just having the one item and have the a pile up of items in later meetings. Okay, so if that's all, I'll close the meeting. Thank you very much.